Good afternoon, dear friends. Let me thank Mr. Pradeep Tripathi and Company Chipla for giving me this opportunity to talk on how to approach infertility couples or how to manage infertility patients. That is in short. And see what I am going to tell you is I'm sharing whatever we are doing in our unit. And that does not mean everybody should accept it. Actually, the purpose of my presentation of approaching infertile couple from my unit is I would like to have your opinion, criticism, so that we can do better. And if you accept, if I am whatever telling is sensible and may help at least some, if it is true and it is sensible, I think some of you can adopt it from our side also. So, hello. See, to start, I would like to draw your attention at two things about infertility before telling the actual approach, how actual management of infertile couples, which will have some influence in our management of infertility patients. One is there any increase in our infertility patients, increasing prevalence? See, 2-3 things are there. Of course, more and more patients are coming to us for treatment compared to about 30-40 years, where they were reluctant to come to the hospital. Of course, that's why we have around 50 infertility IVF centers in Kerala, or all over India, around 2,500 infertility centers are there. Second, probably one reason that really has got some impact on our infertility, increase in infertility couples, that a lifestyle. If I say lifestyle, nothing like smoking, drinking, but age of the marriage. That is a change, a drastic change that has come in our society, and actually it has contributed so many patients infertile, and probably the most important reason for the increase in infertility patients. Third, probably many of us were not very taken it seriously, is the decreased sexual frequency in the couple. Especially this is seen in upper educated class of patients. Probably their priority is different in life. They do sex only to have a baby, and actually they come on that, look at the app, look at the ovulation date, look at the menstrual cycle, and timed intercourse. Actually what happens is timed intercourse will reduce the sexual pleasure, probably reducing the sexual frequency, and probably a lot of patients develop performance anxiety by doing such things. See, this I am telling specifically because it is quite different from the days which we practice. We never even bothered to ask about sexual frequency. And unless and until you ask specifically for this sexual frequency, about how many times you have, you really miss it, because these people are upper educated. They don't come up with all the details. They think, what is this nonsense what he is asking? But definitely we have to make sure that sexual frequency is good. That has got many impacts on the infertility practice. Now another thing, the change of the impact of different causes, like all the books says that about 30% is female, 30% male factor, 30% combined, 10% unexplained factor. But see, if you take a group patient who come to us with a long period of infertility, 5 to 6 years, they come married 5 to 6 years, they come for a checkup. See, if you take 100 patients, definitely you can see more than 50% of infertility is due to male problems. What is the reason? What is the reason here? That is what. See, we are all gynecologists, most of the infertility specialists. I think most of us are ignoring about male disease. And see, we don't know much about the pathophysiology of the male. We are experts in female pathology. See, we have a tendency to ignore male factor. First they come, now you do semen analysis, maybe something is below normal, you give some medicine and take it granted. And just you don't even look back and see, repeat the semen analysis. So we totally miss that group of patients. And male patients are almost always ignored for follow-up. That's the main problem that we are missing. Another thing, even if you're very serious and looking repeatedly, doing all the tests, DNA fragmentation, hormones, everything, see, the treatment prospects for male infertility is very bad. Most of the male factors are not amenable to treatment. That's a major cause of why we are seeing a lot of male patients in a group of infertility patients with long period of infertility. So what is the importance of the problem? When a patient comes after a long period of infertility, and maybe most of the time unexplained infertility, they don't know why, and especially when there is no definite female, definitely you have to look back, is there any male factor in there, at least to know that there is a, what is the reason of the this infertility in that particular couple. Can you tell another thing that we come across in many of the infertility patients with unexplained infertility? Recently, we are getting a lot of unexplained infertility patients with low AMH. That's from female side. Just I told just a casual remark in this particular situation. And see, now I will come to the topic mainly. What all things should come to your mind when a couple is sitting in front of you? One is the age, female age, probably the most important thing. How long they have been trying. Of course, they come as a couple. They most of the time you know the roughly the diagnosis. What is the fertility status of the partner? Suppose the patient has come to the oligospermia. What about the female? Is she normal, perfect, everything like that? That also adds your treatment prospects and actual cause of whether endometriosis, oligospermia, whatever. Lifestyle. When I say lifestyle, again, I'm talking about whether they are staying together, so like that, so many things. And always, when you start first visit itself, try to have a professional diagnosis. That will help you a lot in the management of the infertility couple, and always manage the couple together. Now, a little detail about the different factors, about the age. What is the most important deciding factor in the management? Age is the most important deciding factor in the management. See, you know the fecundity of a couple, young couple, normal couple, both husband and female is normal, is only 25%. That means they have to have sex, uninterrupted sex. A normal couple should have an uninterrupted sexual life and have to have a baby. And they take 4 months. Suppose on the opposite side, they need 40 months at the age of 40. That is the drastic difference, because the chances of pregnancy from 25 years to 40 years. Because you have to give a lot of importance to the age of the patient. And yeah, above the age of not 40, above the age of 30, you should have a structured treatment after the age of 35. See, it is almost like an emergency. Hey, what is happening because of the age? All of you know, because of ovarian reserve, the number of follicles are coming out down, and why? More than that, the embryos formed after the age of 40 in a patient, almost at the age of 25, it's almost 60 to 70% of embryos are euploid embryos. But at the age, after the age of 35, 40, most of them are aneuploids, because they cannot continue as a pregnancy. They cannot go implantation and do implantation. Another thing is that mitochondrial deformities are very high after the age of 35 or 40. So after the 35, I think you should take it seriously and do the best available treatment. they deserve that advanced treatment after the age of 35. That is what. Now, trying time. See, this is also equally important how far they have been trying time. We come across two situations. One, they are married long time, they are staying together with all investigation within normally. See, what does that mean? Many doctors say, don't worry, you will get pregnant. That everything is normal. Even after so many years trying, no pregnancy, that does not mean that whatever we see is normal. But that does not mean that they are normal. There is something wrong which we cannot find out. That is what I mean. Again, this group of patients need advanced treatment. Another group we say, no, they are married, but they could not stay for a long time. 10 years married, hardly they have stayed 10 months at different intervals. But here also, I think we have to take it seriously. You cannot just lag the investigations and treatment because they will get aged. So long period of trying time really is a serious matter that can have a lot of impact for the success of fertility treatment. And it is advisable to give trying time at the same time. You can give some trying time for some abnormal sperm, unexplained infertility in young couples. I'm not talking about the elderly couples. Young couples, of course, there is no harm in giving some trying time initial period of life. You can lag the investigation if they are young. But of course, trying time is long. I think you have to take it seriously and do best possible to that couple. See, another thing now, see, fertility status of the couple. See, it's a very good example if I say 2 plus 2 is 4 and 3 plus 1 is also 4. If good fertility status is good in one couple, where large possibility, there's a possibility that the other couple can compensate to get a baby. Best example I should say is the PCOS with good semen parameters. PCOS, I mean, they're not an ovulatory cycles, oligo-ovulatory patients. The husband is staying together, good semen parameters. They conceive, most of the time they conceive normally, provided they are staying together. Another example may be normal cycles with good IMS. Even with a poor semen parameters, they do conceive. But on the contrary, a severe endometriosis with semen parameters, you should go for the most advanced treatment as early as possible. But none of the other treatment will be helpful to get a baby for this patient. And then again, of course, lifestyle. This lifestyle, when I say they are not staying together, we get a lot of couples, they are not staying together, timed intercourse, poor sexual frequency, drinking, smoking, all the bad habits. I think these are again difficult patients. You have to pay a lot of attention to change their lifestyle, unless it is going to be very difficult to manage. These couples have to concentrate on such changes and counsel them properly to get a baby otherwise. Now, actual cause. See, some of the causes, suppose vascular bilateral tubal ectopic, tubes removed, tuberculosis, tube damage with the tubal block. See, there is no purpose of waiting here. You can go ahead and do the most advanced treatment as early as possible. Now, see, this very important symbol thing we have to remember when you go for that treatment of infertility couple. You take what are the most common cause of failure. If you take 100 patients of IVF patients, if you look at these patients, 70 to 80% of the cases, it decides the fertility in our group of patients. The most important deciding factor in the fertility treatment is the egg, or in other words, female egg. And in a very less group of that, this endometrium and actual with the after the advent of ICSI, the chances the sperm parameters or the male factor has not giving much importance to failures. Most of them can be treated successfully. Now coming to the little about male factors. See, I don't know the classification seen in the books, but we look at it in a different way. If you look 100 patients with oligoacinospermia and you examine them, you do all investigations and you look for everything you do, but see, you don't see any reason why there is oligoacinospermia. See, there are two explanations given in the books. One is that during the intrauterine period of that particular male, that some abnormal exposure of estrogens to of the testis, and because of that, the cells do not coordinate, and probably that is one reason there is oligoacinospermia. Another explanation probably is a partial block. That sperm is not coming out because of the partial block, and that's the most common explanation given, but it can be due to some chromosomal anomaly, some genetic mutation, something that as set of gene mutations. There are so many things it can be, but we have no explanation. At the same time, we cannot treat. There is no proper treatment to this group of patients. A very small another group what you can see is that, for example, FSH is high. It's a testicular failure, impending testicular failure. So what you can do, you cannot treat in such patient. You have a patient with nephrotic syndrome. You have patient congestive cardiac failure, oligospermia. We have such patients. Actually, there's no even we know the cause. We don't know the treatment. And finally, we have some group of patients with like causes that can be treated, and we can expect some results after the treatment, like see, these are the usual causes explained: varicocele, hydrocele, hernia, and diabetes, infections. If you medical causes, infection, hypogonadotrophic hypogonadism, thyroid, hyperprolactinemia, of course, change of habits like smoking, drinking, all these things. See, but suppose, but usually if you take 100 patients, I told you, 70% we cannot have no explanation, but treatable causes if you take is only around 25%. That means, as an infertility specialist, you have to see any of these causes are there in the male, then only actually sensibly you have a definite treatment. That you have to keep it in mind. Just all what we are treating is just symptomatic or some antioxidants. You are buying time from the patient. Now see, we are all depending upon assessment of the male, semen analysis. But unfortunately, there are so many pitfalls for semen analysis. I don't know whether anybody of you have seriously taken it. Parameters vary from sample to sample, technician to technician, and lab to lab. And see, what is the cause? Explanation given. Why there is parameters different? Two explanations given is, one is, see, it is not like taking blood or urine. It is taken by masturbation. See, masturbation decides many times the quality and quantity of sperm. That's one explanation given why it is different. Another thing, during the semen analysis, I don't know how many of you have really involved in semen analysis lab. See, you take one drop of semen from a liquefied sample and take it under the slide and count and give the report. See, we take it granted that particular drop is representing the whole sample. It may not happen. So that is the most difficult situation in a semen analysis report. And see, another thing, you get a very good semen analysis, but that does not tell you that particular man is fertile. And another possible thing is that we have no upper or lower limit of semen analysis, which we cannot predict that this particular man will is fertile or infertile. Another funny situation that we have seen is man may be fertile to one female and infertile to another female. This also we have seen in our during our practice. But see, what is the importance of this particular problem? See, we all our RCTs. are depending on the semen analysis report, the count, and mainly the count. See, how can you really depend, especially when you don't know, you are not sure that even small, very small number of sperms in the semen can conceive. How can you depend on the success rate of this or whatever studies that is seen in the RCT, so some antioxidants, some injections, some whatever treatments for we are giving to how to really do studies in the male. It is very difficult, and it is very difficult to believe all these RCTs because a semen analysis can vary like anything, and you cannot even predict just because somebody has conceived. It is because of your treatment and secondary and the RCT coming out of that treatment. You can never believe. That is the real problem with male infertility. See, another, of course, all of you know, I want to show you should do one important thing which nobody is doing. You should do staining morphology of the semen analysis report, and probably the motility and morphology is more important than count. Now, see, I told you, even though we are telling, no, see, we cannot fully depend upon the semen analysis report. See, we can treat this patient, you will conceive without normally, or you will conceive IUI, we will conceive with only by IVF. It is very difficult to predict by seeing the semen analysis report. But some indication by you can give by looking at the semen sample. Suppose you get a consistently poor motility. Suppose you have a consistently very poor sperms in their semen analysis, 2-3 sperms or less than, always it's less than 1 million, and severe abnormal morphology. You can always see, you can consider most of the time, this particular group of patients are going for ART or ICSI. Because even though the patient is young, if you want, you can wait, but always keep in the mind, this is a candidate for ART, so that unnecessarily delay in the advanced treatment will not occur. And another example is FSH. FSH is more than 8. An indication is tell you that you are dealing with a patient impending testicular failure. See, we are all gynecologists. We see, suppose what will happen to the FSH of the female is more than 10 or 12. Of course, now I feel it is more than 8 is really telling you an impending ovarian failure. And the prognosis like that, female also, a patient comes to you with high FSH more than 8. That is an indication to tell you that you are dealing with a patient impending testicular failure. Sometimes this high FSH with very low count may go for total azoospermic patients. If the count is very low, I think you should take it up early rather than don't delay the patient. If there is some count, of course, there is no harm in waiting. Another thing now, factors that may enhance infertility in poor semen analysis. This is another interesting factor. I read that what I told you before, 2 plus 2 is 4, 3 plus 1 or 3 plus 1 is also 4. See, even poor semen analysis report, many patients conceive. But what are the other favorable points that can improve the pregnancy rate in a male infertility with poor semen analysis report? Couples staying together, see, they get more chances. So getting a chance to get into any and increased frequency of sexual life. That's another reason they get better chance to get a pregnancy, and especially with good ovarian reserve. And another thing what I've seen is good cervical factor. Good cervical factor means good cervical secretion in the vagina during the intercourse. Actually, it helps the sperm migration to reach into the uterus. Even if the number is less, if the flowing of the cervical secretions are good, it can swim and get into the uterus. It can really improve the pregnancy rate with a good cervical factor. See, azoospermia is always a complicated this thing in our textbooks, but we can do it very simply, very easy to diagnose and give a rough see prognosis and the treatment what they really they should look for. Very simple. Actually, even you need not examine. I don't say that you should not examine. Actually, because most of you, the gynecologists are female, they are reluctant to examine. And I don't think once they are reluctant, they can be an expert in examination of the testes, epididymis, was and all. Those who are doing it fine. But I don't think it is a must to diagnose and treat azoospermia. That's why it is very simple. What you don't look at the reason why they are azoospermic. Just we want to know this what type of azoospermia is there. There are only three conditions. One is hypogonadotropic, whatever may be it is. Gonadotropin secretion is zero, and then obstructive. The testis is normal, the patient is producing sperm, but it cannot come out because of there is an obstruction. Third, FSH is non-obstructive testicular failure. See how to diagnose. Simply do the FSH estimation. And most of the time, hypogonadotropic hypogonadism, it will be always less than 3. And if you want to do testosterone along with that, testosterone level also will be 0 in hypogonadotropic hypertension. This is the only condition which can be treated medically. Better prognosis with adult onset hypogonadism. Congenital, the prognosis is not good. So you have diagnosed it, you have treated that. You know what is the treatment, you know the prognosis. Second, obstructive. The FSH is between 3 to 7. If 99% you are dealing with the patient of obstructive azoospermia, depending upon type of size of where the site of obstruction. Vasectomy patient, you can do repair. Other say epididymovacial anastomosis, ejaculated duct obstruction and all. Usually nowadays nobody is doing. They directly go for testicular aspiration from the testis and go for ART. In FSH is high, more than 7. See, mostly 99.9% you are dealing with a non-obstructive azoospermia. See, that only treatment, no treatment for such condition. You only best possible avail of option to have a parent, a child of their own is micro-TISA ICSI. Here, depending upon the size of the testes, the size and how bad the FSH is, you can roughly tell the prognosis. But this the only treatment with the testicular failure or non-obstructive azoospermia is a micro-TISA ICSI. Now I am coming to the female factors. The most common was ovulatory problem. After that, PCOS, 90% PCOS, but like hyperplatinum, hyperthyroid, adult onset syndrome, Cushing syndrome, tuberperitoneal factors and lutein factors. PCOS, yes, there are 3 things to diagnose: anovulation or oligoovulation, factors of hyperandrogenism, ultrasound PCOS, features of PCOS. That is how at least 2 factors should be there to diagnose, to know that you are dealing with a PCO patient. But see, one important thing what you have to remember, many of these patients are having ovulation. I mean, especially if PCO patient with a regular cycles is unlikely to be infertile due to PCOS because they are ovulating normally. And they may not need any treatment for PCOS. Now, if you take the treatment prospects, reduction of the weight when they are obese patients, induction of ovulation by CC, letrozole, HMP, recombinant FSH, depending upon the type of patients. Another thing is the PCO delay. See, we used to have a lot of patients in early 90s, so a lot of patients had PCO delay for PCO. Now, I think we believe that it is not very effective for the induction of ovulation. And finally, a small group of patients end up in ART. The role of insulin sensitizers is probably not very much accepted now. Even metformin is given only to resistant patients who are not responding to CC and HMG and with abnormal GTT. There are only two groups. I scientifically proved that otherwise it is not very useful. See, if you take the total treatment prospects, see, as I told you, almost 20% of the patients with oligo-ovulation or ovulation who may conceive just by increasing sexual frequency chain together. In the oligo patients, what will happen? They are ovulating instead of 14th day, they are ovulating 20th or 25th or 30th day. If the husband is staying together, they have a normal sexual life, they will conceive. Like you have to counsel them, especially if the thing is normal, only this with some variation in the ovulation or sometimes even normal. Don't worry, there's nothing to worry about PCOS. Definitely some 20% will conceive normally. Another 40% may respond to oral ovulation. I don't see much difference with the CC or letrozole. Of course, letrozole, they say that number of follicles is less. Probably there's a reduced tendency to produce multiple pregnancies. And another, if they are not responding, another 20% will go for gonadotropins. But laparoscopic ovarian drilling again may give us another 5% pregnancy. But here what you have to remember is small group of patients with they have a genetics associated with genetic abnormality in this PCO patient will have poor results even after. Because when you see suddenly you get a lot of follicles in this group of patients, but we need to take out this group of patients. Most of them, see, sometimes you get don't get even single egg from them, good egg from all these eggs are immature eggs, abnormal eggs, so many, very rarely you get into such a, so that is possible with PCO patients even some small, very small group of patients cannot get a pregnancy at all. See, even though you are doing a lot of thyroid, other hormones, prolactin, everything, I think the group of patients that we come across really because anovulatory, because of thyroid and prolactin, I think it is very rare. That's what we have felt. Then coming to endometriosis. See, here, see, when you talk, you know that there is no role for any medical treatment, and gold laparoscopy is the gold standard. Laparoscopy is the gold standard for endometriosis treatment. But the fact we now know it's a chronic lifelong disease. Number two, almost 100% recurrence is there for endometriotic surgery, and the surgical treatment has a definite harmful effect on the ovarian reserve, and surgery only restores anatomy temporarily, just to patient given opportunity to conceive when the normal anatomy is there. That is the only thing that surgery is doing. But mainly we do the surgery to restore the anatomy. But suppose even if you restore the anatomy, it is associated with the very factor or some sexual problem. I don't think they are going to conceive with your surgery. Another thing what is commonly seen, do not attempt surgery in elderly patients, because already patients with endometriosis has a poor ovarian closure, and there will be, when you should not do surgery when there is a established tubal block, when there is an abnormal male factor and uncorrected sexual problem. ART should be the first choice in such couples. So this laparoscopy is not gold standard, and see the number of laparoscopy surgery done on endometriotic patients has really drastically come down because of this reason. And what else you should be careful about after laparoscopic surgery? First surgery, always the best surgery, that you should get a pregnancy. The best surgeon should do the laparoscopic surgery in endometriosis. And because the pregnancy rate immediately after surgery is better, and only pregnancy can cure endometriosis to a certain extent. No medical treatment should be given after the surgery. Couple should be together after the surgery. You do the surgery and husband is coming after 1 year, or husband is not there when you do surgery. I don't think there is any reason to do surgery, especially in infertility patients. And if there is any male factor like varicocele, which is called oligospermia, you should treat that first. Then only go for a endometriotic surgery. And when the husband is not there, you should never do the surgery. Regarding the fibroids, you see, you have any number of books on opinion and books on fibroid, whether to operate, not to operate, everything is there. But generally, large multiple fibroids need surgery. There is no question about it. Submucous fibroid need to be removed. There is no confusion about it. Small fibroids, when you are doing for surgery, other surgery, diagnostic laparoscopy, yes, you have to do it. But small, very small multiple steps, 0.5 centimeter, 1 centimeter fibroid, 20, 15. See, how can you remove it first of all? Even if you remove, whether you are going to damage the uterus, endometrium, we cannot say. So in such cases, it is better that you go for suppression of the DNRH suppression or ulipristal something to reduce the size whatever possible, and go for some ART procedures later. Coming to the another interesting thing, which I think most of us are not very serious about it, is over enthusiastic histoscopic myectomy should be avoided. Large myomas, as even if a myoma is smaller, 2 or 3 centimeters, when they have a wide base, and should not be tackled by histoscopy. And it is always better to remove larger myomas laparoscopically, because suppose you damage the endometrium, it's a permanent damage. Finally, that uterus, you have to go for a surrogate uterus if you damage the endometrium. That's a permanent damage. So don't be over it, because we are doing a lot of, after histoscopic surgery has become popular, we are doing a lot of laparoscopic surgeries, submucous myomas, all myomas, they want to take it out to laparoscopically. But they are not worried, or they are not ignorant, aware that it can damage the endometrium, producing a permanent damage to the fertility. So don't do any over enthusiastic histoscopic surgery for removing the fibroid. See, what is the most common complications after the myomectomy? Whether you are doing abdominal myomectomy or laparoscopic myomectomy, definitely there is more than 50% of the chance of adhesion. That is, post-operative adhesions are very common in myoma. Another thing is rupture. What is the cause of rupture? I think two important things that is causing rupture of uterus after myomectomy: overzealous use of pottery. If you once you stop using pottery, the incidence of rupture has come down, and the hematomas at the suture site. This is another reason why the possibility of rupture. But see, another thing what I want to tell you is that if there are more, you don't get a pregnancy after in a young patient, even after a good laparoscopic surgery, everything is normal. I think there is a small place for a second look laparoscopy, because most of the time your second look laparoscopy can remove the adhesions, very simple adhesions easily, that can really get help the patient to get a normal conception. Uterine anomalies. Coming to the uterine anomalies, see two types of didelphys and septic. See, because after the advent of transvaginal ultrasound, see, we have started diagnosing and treating a lot of septum. Septum, probably the most common uterine anomaly that we see routinely. Immediately, once the septum is subseptum, this septum, that septum, if it's all septums, complete septum, broad septum, so many septums, you see. The first temptation is to do a histoscopic resection of the septum. But see, we all had lot of normal conceptions, normal delivery, maybe finally some premature deliveries, mid-trimester abortions, even normal pregnancies, normal deliveries we had with the septum previously before our ultrasound or histoscopy. But the thing is that if it is causing secondary infertility, fine. I think you can go for resection of the with the RPL. But in primary infertility patients, I feel really fried. We have seen a lot of patients who had histoscopic resection of the septum. See, never get pregnancy even after ART. Probably there is a small place. If they maybe just to do something else, second thing, it can cause damage to endometrium again and may be responsible. So I think we will relax for some time, see whether the patient can conceive otherwise. And then maybe if you get 1 or 2 RPL, mid-trivascularly abortions, maybe you can try. Or you just wait, you'll get a normal conception full-time baby in the second or third attempt of pregnancy. Tubal disease, of course, proximal tubal disease, of course, due to infection. Proximal tubal block we used to have a lot of cannulation, but distal tubal block always, I think we'll have to go for ART. Something about the intrauterine insemination. Now, see, what actually we do to help the pregnancy in intrauterine insemination? The principle. See, we are depositing the prepared semen nearer to the site of ovulation on the day of ovulation in a superovulated woman. That means whatever sperms available get an opportunity to get more number of eggs. So the chance of conception is better. That is the only thing that is happening in the IUI. You see, that helps you to get a. That means sperms render the sperms the opportunity to get exposed to more number of ova. And even after that, your success rate is only 10 to 15%. I feel the only indication, the best indication possible is donor insemination, because you cannot do donor insemination for just fresh samples. And sexual problems, if you have no other way, if it cannot be treated. Poor cervical factor, I think it's a very, I told you, cervical secretions are not good, can affect sperm aggregation in these patients. And in moderate oligoasterotomia, IUI definitely will improve the success rate in such patients. And difficult indication of ovulation, because after some PCO patients are very difficult. Even after so many days of injection, you get a good ovulation. You want to take advantage of that particular situation. Probably along with sex, you can go for IUI. Use of otherwise, the use is questionable in severe bearing factor infertility, pelvic factors like endometriosis and unexplained infertility. Why I am telling that IUI has got a don't think it is very simple, and it has nothing, no problems for doing IUI. You see, it is known, everybody knows that DNA fragmentation definitely increase during processing of the sperms. Another thing, see, all these sperms get capacitated after the DNC. That means they become actively motile. Once capacitation comes, what happens? They will die within 12 to 24 hours compared to a normal sperm deposit in the vagina, where they can live so many days. See, that means unless they come in contact with the egg within 12 to 14 hours, that will go for a failure. And see, again, for doing IUI, you have to do masturbation Sometimes the masturbation by itself can reduce the quality of the sperm. And of course, even though it is a simple invasive procedure, it is a small thing that you can go endometritis for these patients, and unnecessary IUI should be avoided. See, many people are against this postpartum test. I see, but properly used for one simple reason. You do a postpartum test around the pre-ovulatory period when the patient comes. Don't have any, you come, do sex, you come after 6 hours. Don't do something like that. You just do a postpartum test. Recently, the day before the patient has sex, and for, even if your first consultation, you see the cervical section, take a drop of it, see under the microscope, do a seminar, see if it is, you see a few sperms in that, good sperms in that cervical secretion. You have going to completely rule out the male infertility and sexual problem and cervical factor. See, very simple, no? You can just don't even need to do a semen analysis if you do see a good person. Negative, don't worry, there is no relevance. But still, I feel it's a very, especially this you see in patients who had collection problems. You ask them to have sex and come, definitely you can see good sperm. That means there is male is normal. Like that, so many good things are can be had in your routine work by postpartum test. Only you should try. Don't just go behind all these articles and all. See, another thing, see, now AR match and ovarian research. The thing is whether you should do is accepted ovarian, the best, one of the best available tests. MH below 2 grams, that means a poor ovarian prognosis. Is AMH is needed as preliminary. That is and see, I've seen a lot of patients with unexplained infertility with low AMH after 3, 4, 5 years after this. If they had done an AMH before, they should not have missed it. Actually, you are doing a criminal offense by not taking that, even though it is costly. Suppose that you could have done AMH early and you could have done a structured treatment. You should have gone taking the most advanced treatment possible. At that time, you should not have wasted this much time to the patient. Now, see, AMH completely slowly deteriorate. After some time, you will not have, they will lose the chance of having their own child. Even though it is not very costly, I think it is worth doing AMH even in your first visit. Even people like me, you are doing a lot of transvaginal ultrasound looking for ovarian reserve and follicle count. Really, we miss at least in some cases. And another thing what I have found, even with good follicular count and do AMH if it is poor, you see patients like below 1.5, 1 AMH, you get some small group of patients. When you do IVF, you take out the gaps. The quality of eggs are not good in such patients, even with a good number of follicular count. So I think AMH is very important and investigation for which you help you for decision making. And according to me, it should be a preliminary investigation for unless you are very definite there is some other reason for their infertility. See something about, I think it will not be completely fine. Don't say something about sexual problems. See, when it comes to male, loss of libido, erectile is common. Erectile dysfunction, penetration problem, ejaculation dysfunction. These are the common complaints that we come across in the infertile patients. See, unless the male is diabetic, some epileptic patients on drugs, or psychiatric patients, I think most of the time, this group of patients, they are young patients, nothing like a testosterone deficit. Most of the time, it is a performance anxiety that we come across. And this group of patients, you can do good counseling along with the wife, some sort of relaxation exercise, yoga, or some relaxation. You can either give a long-term small dose of sildenafil group of drugs or anxiety drug to these patients and avoid asking them to do sex on a particular time. You take this drug, you go at 8 o'clock, you take 10 o'clock, you start trying. Like that, you avoid perform anxiety producing programs and take that small dose drug regularly and let them have a spontaneous uh, sexual feeling and do sex at whatever time they want. That usually helps you to treat sort of problems in most of the patients. That's our routine things and a little bit of counseling, some relaxation, and that is the best policy to treat our most common sexual problems that we come across during infertility. And coming to the female vaginismus, yes, again, this vaginismus is common in the upper educated class of females, and we see a lot of patients in the our group. This is also part of performance anxiety. They are afraid that if something they have heard, that something is against their sex, they have understood. Sex is a sin. They don't want to avoid it. They are afraid of getting a pregnancy. They are worried about the complications. Some people are even worried about having an abnormal baby after after the delivery. Everything probably sees want to avoid the vaginismus. So our duty is to remove that anxiety. Nothing else. The best way to remove the anxiety is, of course, again, counseling. Ask them to dilate the vagina with their own finger with lubrication. Otherwise, the patient will not allow either the doctor or the husband or wherever it is to do the dilatation, because we should counsel this patient to dilate the vagina by herself, slowly, one finger, two finger, three finger, like that. Definitely after some time, they feel confident that it's not going to give pain, and slowly, at least for the 50% of the time, you will be successful if you do this particular policy. And I think most of the time you will be able to treat moderate sexual problem by yourself during your infertility work. And finally, to conclude, always have that's very, very important according to even from the very beginning, and investigate and manage along the line of professional diagnosis. And thank you very much for your attention. And I thank once more Chipla and Tripathi for your helping me to conduct this session. So hello. 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 Is there anything to do? Any controversies I have? Any controversies? Any? Yes. Yeah. പക്ഷെ നിങ്ങളുടെ ഉത്തരം പറയാൻ ഒരിക്കലും ഒരു ക്വസ്റ്റ്യൻസ് ഒക്കെ ഉണ്ടാവില്ല. അതൊന്നും വന്നില്ല. ഹലോ, അതല്ല നേരത്തെ ഞാൻ എത്ര പ്രാവശ്യം നോക്കിയിരുന്നു ഇതിനു വേണ്ടി. കേട്ടു, എത്ര പേര് കേട്ടു? Yeah, sure, sure. Can you choose our mail? So WhatsApp or email? One second. Yeah. Okay. 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 Question I think Hello, Dr. Jayasri. Serum AMH levels are coming less than 2 for some women in their 30s, and FC seems okay. How to correlate? I think, we had a lot of problems with the initial type of AMH assessment. This is the 4th generation which we are doing. I think this gives a very good result, and that is really correlating to your pregnancy rate. MC, if I get a patient with a low AMH, I am really worried. Not that you should jump into AMH, but definitely you should do a structured treatment, whatever possible things to get achieve an early pregnancy. And another thing, I've seen a lot of patients with when the AMH is low, even if you get good X number of X also, the implantation rate is very low. That means it is reflecting the quality of the egg, not only the quantity, even though all the books say it only count that matters, not the quality. But I think it is the wrong message they are giving. It definitely is this thing. It is giving you an idea about the quality also. Taking for laparoscopy. What is it? Infertility. Infertility. Bindu, hello, Bindu. Hello, Bindu. They are asking me the indications for laparoscopy. Actually, the number of laparoscopy nowadays we do for infertility is very less. Small fibroids and all we don't do. Actually, the main indications for, of course, definitely endometriosis or some ovarian cyst adherent when we are suspecting some additions, and unexplained infertility to make sure that there is no pelvic factor. That otherwise the indication for actually laparoscopy has really come down for the laparoscopy. Then thank you. A large endometrium, what will we do? A young couple with excellent main factor. I see whatever may be the size of the cyst, you can get pregnancy. You can wait for some time in young patients with good ovarian or even with a large cyst. Of course, we have everything is normal. Probably after waiting 6 months, 1 year, whatever may be the size of your endometriotic cyst, we get sometimes pregnancy because we are not sure after the surgery what will be the status of your pelvic anatomy. So always give some opportunity to conceive normally, and if it is not happening, definitely, of course, your option will be going for surgery. Thank you, Srivedin. Thank you, Vidya. Very informative presentation as usual. Wonderful exercise. We do AMH even after the first USC in a young female if we doubt regarding the result. See, definitely, I will not compel you to do AMH even when the looks very fine everything. At least when you see, we are thinking that it's an unexplained infertility. We don't see anything else. We don't expect anything else other than it. Definitely there is a place for AMH, even if you think there is a good AMH count. Sir, can you do IUI in the same cycle in which HST is done? See, I had so many pregnancies, normal pregnancies by HST. Why not? You can do HST also, IUI also after your HST. Thank you. So many people. See, anti-sperm antibody, regarding the anti-sperm antibody, see, first of all, anti-sperm antibody treatment, there are two types of anti-sperm antibody available here. One is surface antibody, actually that is the thing which can cause infertility. That serum antibody is what we usually continue to do, anti-sperm antibody in male and female. Usually it is not the cause of infertility. The surface antigen present on the spermatozoa, that is causing immotility and penetration into the sperm, that is responsible for infertility. You have an immunobate test to do that. But you see, then after 100 sperms, 10 sperms are immunobate positive. But again, that test is not very useful. But if you get a patient with history of trauma or history of surgery to the testes, you get a lot of agglutination. You have a bad postcoital test if they good sperm. Probably you can assume that it's a case of anti-sperm antibodies. See, I don't know how to tell this. A lot of basics of ovulation induction. I think there are two things. Most of the time we do induction of ovulation for a normal ovulating woman. Just to any patient who comes to you, that is the practice of infertility unit. But how far it is really helping the patient to conceive, I don't know. But see, hypogonadotrophic hypogonadism, you have only way of induction of ovulation is gonadotrophic. A normal FSH, that means type 2 amenorrhea patients, of course, you can use all these CC letters or HMG depending upon the this thing. Adrenal follicular count. What are the other factors responsible? Well, I love that ovulation induction. Like that, I don't know how much I can tell you about basic. The relevance to postcoital test this day. Why these days? Why you are asking these days? What is the harm in doing a postcoital test? If the patient is coming to you on the pre-ovulation day, previous ovulation, peri-ovulatory. What is the against that ovulation? That's what I don't. Just take one drop of secretion, see under the microscope. If you see the sperm, it gives you a lot of information. What is the relevance of this day or that day? It is relevant all the days, and it is a very useful test as far as I know from my experience. I don't care about so many people are telling no, it is not relevant. It is relevant, right? The simple test that anybody can do in your those who there are a lot of fluctuations in the semen analysis. Many times you cannot interpret the semen analysis because of the masturbation, collection problems, and if so many things are there. But if you see very good sperms, 4 or 5 good active motile sperm in your postcoital cervical secretions, that means I stopped doing any investigations of the male, and almost always it has given me a good helped me as a good practice.